Hey YouTube, welcome back to my channel. Tony here, adult general primary care nurse practitioner, and I'm back with a book review. I know I'm not regular with my videos being uploaded and, well, made, period, but I had some time today, Good Friday, and I decided to put it to good use to give you a review on a book I recently picked up. I saw it advertised and I'm friends with the author on Facebook, and I just had to have it. I'm a book nerd, as some of you know, and so today's video is about this book, 101 Primary Care Case Studies, okay, by the author Sam Wajesing. I hope I did his name justice, okay? He is a PA out of California, and I absolutely fell in love with this book when I saw it on Amazon, and I, looked through the sample pages, and I just had to have it, and I purchased it. And I haven't gone through too many of the cases because, life, gets in the way. I'm busy, but every so often I'll have it in bed with me, and when I find some time, I'll look through a case real quick just to get the brain going. Keep the wheels in the brain lubricated and always working. So today I thought I'd share one case, just give you a sneak peek. And also I believe you can go online to the Springer, the publisher's website, and look at some cases for free so you can get a feel of what the rest of the book looks like, okay? Also, what comes with this book is access to the website, because he doesn't give you the answers to the questions in the book, because he created the book for people to think about the case. By the way, these are real world cases, and he's giving you, what you'll see in the clinic, what he's seeing in the clinic. So he has questions after each case, and I'll say it's about 10 to 15 questions per case average. And they ask you, several things, just make you think of all kind of aspects of the case. So let's take a look at this case. I picked a geriatric patient because they are my heart. All right. So I don't think this age is really geriatric, but officially they are. 65-year-old male patient. He comes in to see his PCP, his primary care provider, and he has this insidious onset of hand and leg numbness and tingling and weakness. In a nutshell, here's a brief history. I'm not going to read everything here to you. He had a motor vehicle accident 15 years ago. No surgery was needed. He had some back pain and whatnot, went through therapy, good as new in a year. All right, that's 15 years ago, so he was, 40 years old. No, sorry, 50 years old. But he was good as new. All right, he's a postal worker. 3 weeks ago, he had some gastroenteritis, had diarrhea for 5 days, went to an urgent care center. They diagnosed him with the gastroenteritis, sent him along his way. This numbness and tingling, though, started 5 days ago. All right, and so he has a glove-like numbness, tingling to his hand. He has numbness and tingling in his legs. It leads to imbalance. On the review of systems, you got some decreased appetite, fatigue, nausea, insomnia, occasional dizziness, and mild blurring of vision, imbalance problems related to numbness, weakness, tingling of the feet. All right, so he has some hypertension, hyperlipidemia. That's it. Well controlled on lisinopril 20, atorvastatin 20. All right. Married with 2 children, works at the postal office. Before this recent onset of weakness and tingling, he enjoyed hiking and biking at least once a week with his wife. No smoking, no recreational drug use. He has a glass of wine with dinner every evening. Usual childhood illnesses. He does have his only family history that might be relevant is he has a mother with lupus. Okay, so No drug allergies, no food allergies. It takes you through the physical exam. For the most part, everything's normal. His vital signs were normal. I would have liked to see his blood pressure a little lower. It was 140/90. But then we get to the musculoskeletal part of the exam. He has full range of motion to neck and shoulder with end range discomfort. His hands are warm and dry. Negative Allen's test. Grasp is equal but weak symmetrically. Muscle wasting is no muscle wasting is noted. I'm sorry. He has some tenderness to deep palpation to the base of the neck, extending to the mid-interscapular areas and laterally to posterior shoulders. Okay, what else? We got some lumbosacral spine with no tenderness. Straight leg raises, negative bilaterally. Okay, so there you have it. Pulses are equal bilaterally, 2+. Normal hair growth, lower and upper extremities. So none of that going on. You know what I'm thinking, peripheral arterial disease now. So when I first read this case, I don't know why GuillainBarre always comes to mind when I see muscle weakness and tingling, in a patient, and it doesn't really say, it didn't really describe his symptoms as ascending or descending, but something about sudden onset muscle weakness, my mind automatically goes to Guillain-Barré. And then, as I read the case through, my mind went to something related to the accident he had 15 years ago. And I remember I took a fall in the dorms at college my freshman year, and I slipped, fell on the stairs. I could feel the step hit into my lower back. In that moment, I got up and I felt fine. I had zero pain. But I remember feeling that step go right into my back. Like as I fell, it's like I fell right onto the step, my lower back, and the edge of that step made contact. But I felt no pain until maybe, I didn't start feeling pain until maybe about 5 years after that, maybe even longer, because that happened freshman year and I was in college for 5 years. So, I don't even think I felt it maybe 7 years after that. So it takes a while for our spine to do stuff. So part of my differential, which is question number 1, what is the differential? So for me, it was some kind of neuropathy from some kind of impingement in the spine, whether it be lower back, neck. Since he's having numbness and tingling everywhere, I'm thinking cervical. And of course, Guillain-Barré is always up there. And then I remembered, seeing a patient in clinic, recent day, and I asked my doctor that I work with, and I said, do you think this guy has Guillain-Barré? And he's like, well, he's been, complaining about this for about a year now. Guillain-Barré is more kind of quick, and it usually happens after a viral illness. What did this guy have 3 weeks ago? He had viral gastroenteritis, diarrhea for 5 days. I'm like, okay. So Guillain-Barré is at the top of my list now. The cervical and the spinal impingements, went down a notch. So let's see what the differential is. Here comes a list of differentials, all right? We got peripheral nerve impingements. That'll be considered based on his initial. And what I love about this book and the associated website is that he breaks it down. He gives you explanations as to why something is considered and why it isn't. So you can understand, because he had this, it can't be that, even though it's, it's like, ooh, okay, that's the symptom may be a hallmark of that, but because of something else, when you're taking your history, doing your physical exam, it's like, okay, it can't be that. So he breaks it down. Nerve impingements must be considered. Cervical stenosis must be considered. Guillain-Barré is a likely diagnosis. Idiopathic malignant plexoneuropathies are unlikely because the pain is typically an insidious onset. It's like gradual, but this was boom, okay? Myasthenia gravis is unlikely because the patient presents with a progressive and constant weakness, and myasthenia gravis tends to fluctuate and is associated with complaints of muscle fatigue. They're usually worse at the end of the day, so it's not constant. So that gives you a window into why certain things. So the next question is, what is the most likely? What are we going to, go to first? And boom, Guillain-Barre. The patient experienced acute onset in less than 7 days and experienced a lack of deep tendon reflexes to periphery, blurred vision, fatigue, and quick progression of symptoms, all factors associated with this disease. Likewise, the patient had a possible precedent event with diarrhea 3 weeks prior to presenting to the clinic. Most important, given the presenting symptoms, a high index of suspicion should be considered by a clinician because of the potential for rapid acceleration of the disease, which may be fatal with respiratory compromise. So, I remember having a nursing school instructor, Maria Rivera. I will love her till the day I die. Okay, I wish I could get in contact with her. I got in contact one time after graduating nursing school, so a couple years after, and I just called her to thank her because, I was in my job as a nurse and it's just something that I was doing at the time. And I remember her instilling that knowledge and that just go get 'em attitude and just taking charge of your education as a nurse. And I just called her and thanked her, like, thank you. I already had it in me because I had parents, and my father was that kind of parent that just, keep going, keep going, keep going. And I know this is a sidebar, but I just had to bring that up because she drove into me, what will kill your patient? You always have to think about that. What will kill your patient? So when I'm formulating a differential, I go to worst case scenario. And I'm like, okay, let's rule this out first. Make sure, because we don't want to kill our patient. So you always go to what will kill your patient. And when I spoke to my doctor that day about that patient, I asked him, like, could it be Guillain-Barre? And he's like, no, well, this, and he explained, he went through it. I said, all right, because, I'm always thinking, worst case scenario. He's like, what will kill your patient? Exactly. You're in my head. So this is, I don't even know why I brought that up. Oh, yes, I do. Because this disease can cause respiratory compromise. I don't want to make this video too long. So let's wrap it up real quick in the next 2 minutes. So it takes you through a whole bunch of demonstrate your understanding about the path, though, in regard to the most likely disease. And he goes through it, okay? Should tests and imaging be ordered? Which ones? Why? Think about tests and imaging beyond the primary care setting as well, because I know we're kind of restricted, in the primary care setting because we don't have all the nice machines available to us in the acute care setting. So he goes through it. Diagnosis of Guillain-Barre is heavily weighted on a clinical presentation because testing during the first 2 weeks of symptoms may not provide any definitive diagnosis. In consideration of the clinical presentations, the PCP sought immediate neurological consultation or neurology buddies and facilitated transition of care for this patient. Further diagnostic studies were deferred as patient was referred immediately to the ED. Okay. Emergency department testing included regular CBC, CMP, UA, heavy metal screening performed to rule out possible metabolic disorders, infective processes as heavy metal intoxication, accounting for some neurotoxicities. Okay. It gives the results of the testing. They did spinal and CT imaging. It's an ED. It's what they do. They did find cervical discogenic DJD, degenerative joint disease. Otherwise, no focal spinal lesions. Mild DJD changes in the cervical and lumbar spine with disc narrowing at C5 and C6, C6 and C7 levels, consistent with moderate discogenic disease. EMG, that's the nerve studies, were obtained to identify patterns consistent for Guillain-Barre, reflected by absence of hallmark H-wave reflex and F-wave latency. This is beyond my pay grade, but some, explanation of those kind of studies. It'll be interesting to look up those studies and figure out, what they mean. What is the next appropriate steps in management? Patient was escorted to the ED, accompanied by his wife, hospital studies with results noted previously. So basically, he's taking you through the steps. So, the last question was about tests, which he kind of jumped ahead because as a primary care provider, there's really no test for us to run. So he went through the tests, and then what's the next appropriate step after figuring out what tests we can run? is the ED. So refer back to the last question. And what are the triggers associated? What are the pertinent ICD-10, CPT, evaluation and management codes for this visit? I mean, he really takes you, he breaks it down. What's the appropriate patient education? If not managed appropriately, what is and are the medical and legal concerns for this case? All right. And think about interprofessional collaboration for this case. Provide a list of specialties or other disciplines and indicate what contribution these professionals might make to managing the patient, okay? And bedside manner questions. What would your communication style or approach be with the patient and his wife? If a patient and his wife are distressed by the diagnosis, what might offer support? And he goes through the outcome, the final outcome of the patient, and insight from the primary care provider. And he provides references, articles that support the case study. I'm not going to give you the final outcome because you have to buy the book to find out. Okay? I gave you a lot of information there, so if you want to know the ending, buy the book. All right? Here it is again. It is available for a deep, deep discount currently on Amazon. I will leave the link in the description below. But I think this is a great book for the NP students and the novice NP and the experienced NP, any NP who's maybe in a specialty and is thinking about going back to primary care. Here's some, things to brush up on, but it just makes you think. It really does. It's literally 101 cases. So there are a lot of cases to look up in this book. He has a nice table of contents, so you could look through and see, maybe you had a patient, you want to see if he has a case study related to that patient. I'm sure every primary care NP out there has had all of these patients, okay? I haven't had all of them, but I've had a good number of them. He has pediatric, he has, adult, regular adult, geriatric adult. So he has something for everybody in here. I highly, highly, highly recommend this book. Once again, here it is. You see it? There it goes. See it? All right. I hope you enjoyed this video. I'm sorry it took a little long, but I just wanted to go through that case and show you how it comes with the companion website, because he does not provide the answers. As you can see, it's all blank. Okay. So you think, go to the case, work through it yourself. If you don't want to mess up your pretty book, take a piece of paper and just go through and just, work it out yourself. Then go to the website, see if you match, see what else you could have come up with, and yeah, get it. Get it. It's on Amazon now for a deep discount, okay? Kind of mad because, I didn't get the discount, but that's okay. It was worth it. It still is. Get the book. All right. I'm not being, a disclaimer, I'm not being paid for promoting this book. I'm a nerd and I really enjoy this book. So I want you to get it. Okay. Thank you. If you like this video, hit the like button. If you enjoyed it and you'd like to share this review with a friend, hit the share button. And if you enjoy me and my lackadaisical ways and my inconsistent video uploading, hit subscribe, all right? Just hit the subscribe button because I got some interesting videos coming up. I have some life news I want to share, but I'm not ready to share it just yet, okay? So, but hit the subscribe button to stay tuned, all right? All right. It's good stuff coming. Good stuff. All right. Stay blessed. Thank you for watching. Keep on washing your hands. I know COVID looks like there's a light at the end of the tunnel, but continue to keep your distance. Continue to wash your hands and wear a mask, okay? Respect your fellow man and respect their personal space, okay? You should, people should have been respecting it before COVID, but even more so now, all right? I know there are some people who don't want to wear a mask. That's okay, but just keep your distance, okay? And, get vaccinated. Hey, I'm not pushing on anybody, but if you don't want to get it, that's your prerogative and that's fine. But respect other people's wishes in that they don't want you that close to them. All right? So take care, love you, stay blessed, and I will see you next time. Ta-ta.